Our next topic deals with ectopy, which is characterized by an impulse that originates somewhere other than the SA node. Because all pacer cells are capable of generating their own impulses, or beats, when you are confronted with a suspected ectopy, you must first identify the underlying rhythm and then name the ectopic beats. For example, ectopic beats that come from above the ventricles are called supraventricular, while those that come from the ventricles are called ventricular ectopy. Ectopic beats that appear early, before the next expected beat, are called premature beats. These premature beats may be produced by the atria, the AV junction, or the ventricles. Beats that appear after they are expected are referred to as escape beats. We can identify premature beats by their site of origin. Premature beats originating in the atria are called PACs, or premature atrial complexes. Those that originate from the AV junction are called PJCs, or premature junctional complexes, and those from the ventricles are called PVCs, or premature ventricular complexes. In this section, we will discuss PACs. The other premature rhythms will be explored later. A premature atrial complex occurs as the result of an irritable focus in the atria that fires prematurely and produces a single ectopic beat. Since a PAC is not an entire rhythm, but instead is an isolated early beat, you must first identify the underlying rhythm. In doing so, do not measure or count the PAC in that underlying rhythm. Then look at the P wave, because an early P wave is the key identifier for a PAC. It may also help that this P wave often appears slightly different than the other P waves. The other features of the beat will vary depending on the type of PAC. With the aberrantly conducted PAC, the conduction through the ventricles remains abnormal, but the bundle branches have not sufficiently repolarized and are slow to respond to the impulses from the atria. In this case, you will have the early P wave and a wide QRS greater than 0.10 seconds. With the non-conducted or blocked PAC, there is no conduction through the ventricles because the atrial focus fires so early that the AV node is still refractory, but yet is not repolarized. This creates an early P wave with no QRS behind it. PACs are fairly common among healthy people and may be triggered by a variety of things, including alcohol, cigarettes, anxiety, fatigue, caffeine, or even some medications. However, PACs can also be associated with some serious conditions, including myocardial ischemia, atrial enlargement, congestive heart failure, and electrolyte imbalances. So how do you treat PACs? If they are infrequent, they may not require any intervention. But frequent PACs may lead to atrial dysrhythmias, so it is very important to identify and fix the underlying cause. This may include correcting an electrolyte imbalance or reducing stress or the consumption of alcohol or caffeine.
Our next rhythm is atrial flutter, an ectopic rhythm that is caused by rapidly firing circuits in the atria that are depolarizing at a rate greater than 250 beats per minute. The AV node is stimulated by this huge number of electrical impulses, but it only transmits some of the impulses to the ventricles, and even then may only do so in varying ratios. Remember that in a healthy heart, this is the AV node's natural way to protect the ventricles from these rapid atrial impulses. We identify a patient with atrial flutter and a ventricular response rate of greater than 100 as having an uncontrolled ventricular rate. Likewise, a patient with a ventricular response rate of less than 100 is considered to have a controlled ventricular rate. This is a very important distinction and should be measured carefully. The P waves produced by this rapid depolarization from the atria are going so fast they look like flutter waves or F waves and have a sawtooth appearance. Let's examine the ECG characteristics for atrial flutter. Rate. Atrial rate is regular between 250 and 400 beats per minute. Ventricular rate, if controlled, is less than 100. If uncontrolled, it is greater than 100. Rhythm. Ventricular rate can be either regular or irregular. It is important to note that atrial flutter can have variable ventricular response that will make the ventricular rhythm look irregular. P waves. Normal P waves are absent and are replaced by the pronounced sawtooth or F waves. PRI, not measurable. QRS, 0.04 to 0.10 seconds. Some of the causes for atrial flutter are the same as those for PACs, including alcohol, cigarettes, anxiety, fatigue, and some medications. Other possible causes include coronary or valvular heart disease or electrolyte imbalances. However, this abnormal rhythm is much more likely to be a result of an underlying pathology such as CAD, ischemia, valvular disorders, COPD, or sometimes even a digoxin or quinidine toxicity. It is also not unusual to see atrial flutter in post-op patients with a coronary artery bypass graft. So how does the ventricular rate affect the patient with atrial flutter? As with any rapid ventricular rate, patients with an uncontrolled rate can experience decreased ventricular filling, which can lead to decreased cardiac output. This, of course, places the patient at greater risk for heart complications. The first step in treating this condition is to, as always, thoroughly assess the patient. The next step is to control the ventricular rate. If it's an uncontrolled ventricular response, a rate greater than 100 beats per minute, you must get it under control or slow the ventricular rate. This can be accomplished through the use of drugs such as calcium channel blockers, beta blockers, or digoxin. If the patient's uncontrolled ventricular response remains unstable, more aggressive intervention is required. The most effective option is cardioversion, which delivers a programmed shock just off the highest or deepest part of the QRS complex, or R wave. This provides enough shock to the heart to get it back in line. Per AHA 2015 guidelines, a 50 joules to 100 joules jolt is recommended. Cardioversion is serious business and requires a physician's order and a physician at the bedside. There must also be a respiratory therapist present in case the patient loses his or her airway as a result of the treatment. Even though the circumstances may be frantic at this point, don't forget your responsibility to be a strong patient advocate and encourage the physician to prescribe a sedative for the procedure. Because even if it is administered at the lowest levels, the patient will feel the shock and some discomfort. To effectively treat this condition, you should also try to convert the atrial ectopic rhythm. You can use an antiarrhythmic medication, countershock, which would be cardioversion ablation or overdrive pacing, which is rarely used. Ablation is a fascinating option. If the patient has a chronic atrial flutter, you can send them to the EPS or the electrophysiology lab, where they will run catheters and perform the ablation. At the lab, they will cut, reroute, and rewire the electrical activity of the heart, as well as reprogram the heart so the normal conduction pattern is followed. The SA node will once again fire to the AV node and then on to the ventricles.
Our last topic in this section deals with atrial fibrillation. It's also called AFib. This condition stems from ectopic focus anywhere in the atria, in which the atria acts as the pacemaker. Like atrial flutter, atrial fibrillation is caused by rapid-firing circuits in the atria. But what happens during AFib is that a multitude of impulses spread through the atria and bombard the AV node, all battling for the chance to be properly conducted. As a result, The atrial muscles fibrillate or quiver and create disorganized, rapid, irregular muscle contractions. In other words, it freaks out. Another way to think of it is to imagine yourself peacefully resting at home after a long day at work, when all at once and without warning,
You've got mail.
Your doorbell chimes, the phone rings, your cell phone chirps, and you hear you've got mail from your computer 10 times in a row. That bombardment of information from multiple sources would probably leave you temporarily confused, and your responses would be uncoordinated and probably not very effective. Likewise, in atrial fibrillation, the patient's atrial contractions are uncoordinated and ineffective, which in turn decreases cardiac output. As with atrial flutter, it is important to observe how the ventricles react to the increased number of electrical impulses in the atrial fibrillation, because a rapid ventricular rate can increase the patient's risk factors. During this quivering state, the blood can stagnate in the atria and clots can form, possibly causing a stroke or pulmonary emboli. Let's look at the ECG characteristics for atrial fibrillation. Rate. The atrial rate is greater than 300 and is not measurable. The ventricular rate may vary. If it is greater than 100, it is uncontrolled AFib. If less than 100, it is controlled AFib. Rhythm. Ventricular rhythm is usually irregular. P waves, none discernible. PR interval, none measurable. QRS, 0.04 to 0.10 seconds. Remember that it's the ventricular rate that is of prime concern. The causes of AFib include the usual suspects: caffeine, alcohol, stress, and fatigue, which can produce AFib in a healthy person. Other possible causes include CAD, acute MI, hypoxia, CHF, hypertension, and valve disease. It is also not uncommon to see atrial fibrillation in a post-operative CABG patient. After carefully assessing the patient, you can begin the appropriate treatment. If the ventricular response is controlled, treat with anticoagulants and antiarrhythmics. If the ventricular response is uncontrolled and the patient is stable, treat with beta blockers, calcium channel blockers, or digoxin to slow the ventricular rate. If the patient is unstable, go immediately to cardioversion. Be aware that this may be a chronic condition for some patients and is well tolerated.